Everyone. I'm really pleased to see you again. We're just going to go and get started so we can make sure we have enough time. I'm going to share my screen. One moment. Can you see my screen, Madhu?
Yes.
Okay.
And can everybody
Great.
put their mics on mute, please?
And it's recording, right, Madhu? Yeah, it is. I
Yes.
can see it. Okay, fantastic. All right, so before I go into this lecture, I just want to kind of allay some fears that people may have of, kind of foreign terminology and things like that. So we know that you all are not epidemiologists, just like we're not journalists, and every field has their own lexicon. They have their own ways of speaking in their own words. And so this is a crash course in epidemiology. As Professor Madhu said, you're getting pretty much like a full epi course, but even though it's just like, it would be reflective if we would have packed this all into one day, but still it's quite detailed and advanced, and really it's to sensitize you to epidemiological concepts and terms, as well as how we do the calculations and really understand what goes on in the background, because a lot of people don't get that insight in any other field. Even for us, if we were dropped into a journalism class for a day, it'd be difficult to understand what a lead is and what a byline. I mean, this is your language, right? So please don't feel overwhelmed. I think it's definitely good to look at the videos and to read the supplemental studies and resources that we have in the Google Drive that will help you to familiarize yourself with these terms and concepts even more. So I just wanted to give that introduction, really. So today we're going to talk about measuring disease occurrence and association. And I just want to thank Professor Madhu for the slides. I've adapted them a bit just because, just to make sure it could fit into this time, because we have 2 lectures today. And I'll be presenting these, yeah. One moment. Okay. So the objective of this lecture is to define commonly used terms and concepts in measuring and estimating disease occurrence and association, simplify interpretation of these measurements, provide examples of correct reporting of these measurements and epidemiological information. So before we just go deep into talking about estimates, calculations, measurements, and things like that, I want to define some kind of basic epi terms that we may just throw around, but may not be familiar to you all. We talk a lot about cohorts, and a cohort is really a group of people who have something in common. So you can see that it comes from a Latin term, which talks about, crowds or companies, and it really had to do with like Roman soldiers and legions, but those people had something in common. They were all soldiers. And so think about that when we use the word cohort. Of course, we could also be talking about cohort design, but for this lecture, we're not so much talking about study designs, but we still use the word cohort when we're talking about a group of people. And so some examples of what, links people together or something that's common, a shared characteristic, it could be geographic location. So if we're looking at, people in Kenya or people in Mombasa specifically, that ties them together, that they live there, that they're there at the moment that we're doing the study. It could also be an exposure. So if you saw the 2x2 table video in the Google Drive, we talk about exposure. It could be a behavior like smoking, and an outcome is likely a disease like lung cancer. So that could be something that people have in common as well. It could also be occupation, like someone being a healthcare worker. So it's important to understand that, cohorts, since human beings move forward in time, like whenever you start a cohort, you usually look forward for that cohort. So it would be prospectively, but you could also, so for example, if you're looking for a disease outcome and the people in the cohort already have that disease outcome, you can also look back to different data to see what the exposure was, or what, would actually be associated or be linked to the current outcome that they have. Another thing to remember about cohorts is that cohorts usually become smaller in size. It's called attrition. So if you think of starting out with 1,000 people and you follow them up for 10 years, in most studies, in most research studies, it's very unlikely that you will finish with 1,000 people. I mean, people die, people leave the cohort because they no longer have something in common with that group. For example, if we are looking at a cohort of healthcare workers and someone stops being a healthcare worker, then they're no longer part of that cohort. So just something to remember is that people leave cohorts, and that's called attrition. And then follow-up is follow-up is looking at who stays in the cohort and who gets a specific outcome. So this is just a graphic to show like what a cohort would look like. A cohort, there's 3 circles here. We have a cohort of smokers, we have a cohort of non-smokers. The entire group is a cohort because we're following them up in a study. And you can see that prospectively, we follow them over time, and then we see what outcomes. So whatever the outcome of interest, if it's a specific disease or any other specific outcome, that's what we would look at in this type of study, or, in this type of study, I would say, yeah. So 2 other terms that I want to define is morbidity and mortality. We don't talk so much specifically using these words in this lecture, but I'm sure you have heard these words before when you've been reporting study results or just talking about COVID or malaria. It's important just to remember that these are 2 measures of disease burden that are commonly used in epidemiology. And they measure the progression or severity of a given health event. So I just try to remember that D is disease, but D is also death, actually. But I remember morbidity for some reason by it having a D in it and it being disease. So morbidity is a state of unwellness. It's really looking at unwellness within a population, which could be, disease, injury, or disability. Mortality is looking at the number of deaths caused by a health event or whatever that you're focusing on in that study or during a specific event or crisis. And mortality is often expressed as a rate, but it can also be expressed as an absolute number, but it's more useful if it's expressed as a rate. So you may have heard, or you may have written even about, death rate or mortality rate. And so mortality has to do with death. So maybe you can tie the T in mortality to the T in death. But anyway, so that's, I'm just trying to think of some things that might help. Okay. And so as we continue, we're going to be talking about a lot of different measures, a lot of different ways to estimate things, and both morbidity and mortality can use these different measures, can be expressed or represented in these different measures. Okay, so this is a handout that is actually in Google Drive, and it's going to be our map for this evening. When you're talking about epidemiology, we're broadly speaking about the relationship between exposure and outcome. And we want to capture that by calculating different measures to explain to us what's happening within that dynamic relationship. So if you start on the left, we're looking at measures of disease frequency. And so that is, well, I'm not going to go into detail which each one is because actually we will go into that very soon, but just know that broadly we have 3 categories looking at disease frequency, so the occurrence, how often they come, how often something is in a population. We're also looking at measures of association, so thinking about exposure and outcome and trying to quantify whatever association that they have, but also looking at measures of potential impact. So really, when you look at measures of potential impact, you're asking, if we remove the exposure, how much benefit will we see in a specific population? So that's kind of the progression that we'll look at this evening. All right, so now we're looking at the 3 most common mathematical parameters that are used in epidemiology, but in a lot of fields actually. And the reason why we're going through, rates, ratios, proportions, and I'll add risk in a moment, is just so everyone can get familiar with these terms, and also so you can recognize them, understand them when you're reporting. So the most important thing to know about this slide is that researchers really have to shape and define the numerator and the denominator. And epidemiology, it's essential to have a denominator. So if you provide a numerator only, so just talking about an absolute number without any context, the context is really the bottom number or the denominator, it's really not helpful. It's very difficult as an epidemiologist or when you're interpreting study data or whatever to do anything with just an absolute number. So if you're saying that, oh, 8 people got sick in so-and-so hospital, that doesn't help anything. That's very difficult to interpret or to translate or to compare to anything that would be helpful to you or to helpful to the population of interest. So I think that is the main thing to take from this slide, that with all these parameters, we need to have both a numerator and a denominator, and the researcher would be the one to really define that. Okay, so let's start with a ratio. So a ratio is actually a general term. Rates and proportions can be included in a ratio. It's important to remember for a ratio that the numerator does not have to be related to the denominator. So you may have seen a ratio, a gender ratio, for example, so men to women. So when I say that the numerator doesn't have to be related to the denominator, if men is the numerator, the denominator is women, there are no men that are actually within the women population, if we're just talking binarily. So it's just a measure that's used to I would say well, we can look at the definitions. The value that's obtained by dividing one quantity by another, but it's not necessarily telling us about an actual proportion of the numerator within the denominator. So now we are talking about proportions. So proportion, the numerator actually absolutely has to be part of the denominator. So a male and female ratio cannot be a proportion. So the case fatality that you all have probably heard a lot is always discussed as a proportion. The case fatality rate, it's called a rate, but it's always a proportion. It's because people who die of COVID, so the numerator, they always come from the people who were infected with COVID. That's the denominator. So there is a relationship between the numerator and the denominator when we're looking at proportions. And proportions can be expressed as a percentage, so percent, so we're looking at 1 out of 100, but it could also be represented as per thousand or per million, whatever is appropriate for the disease that you're looking for. So if a disease is more rare, you might need to use larger numbers to express the proportion. It just depends on how you want to quantify that. I mean, you can see the example here when I was talking about the relationship of fetal death out of live births plus fetal death. So that shows that the denominator actually includes the numerator. Okay, so the next term is risk. So risk is a probability. So risk is expressed as a probability that someone has a certain characteristic. And it's important to remember that risk is a probability that a certain event will happen during a certain time. So if I think of myself and I think of my family history, I think about what is the risk that at my age with a family history of hypertension that I will get hypertension in the next 10 years. So again, it's looking at a specific characteristic over a specific period of time. And risks are bounded by 0 and 1. So if I have a 0 risk, that means I have a 0% chance of getting something. And if my risk equals 1, then I have a 100% probability of, having a disease or having a specific characteristic. And risks are very useful when you are describing individual prognosis. So risk can be used to estimate individuals' chances of survival from a disease or death. So when you go to the doctor, they usually tell you that, okay, because of your blood pressure or your cholesterol, your risk of a heart attack is this. So they're using your independent factors to estimate the risk of a specific outcome. Oh yeah, the bottom is important as well. The risk assumes that it does not have a disease at the start of a follow-up, that you don't have a disease at the start of follow-up. So when someone's actually telling you that your risk is of a certain disease, the starting point is that you don't have that disease. And risk also assumes that you will not die from something else, so a competing risk, which we'll discuss a little bit more in future slides. Okay, so now we're going to talk about rate, which is different from the other three for a key reason. So rate is not the same as risk because rate includes the factor of time. So rate is the only variable where we're talking about this. I'm sorry, it's not just a factor of time, but we're talking about the speed of an occurrence happening. So if you're looking at healthcare workers that may end up with COVID-19 in 3 months, if you say 50% of healthcare workers in Lagos will, and in Lagos hospital will end up with COVID-19 after 3 months, you know the probability of them or the risk of them ending up with that disease is 50%, but everyone might not get it at the same time. So say 40% of people get it within the first, let's say, 4 weeks. The other 10% have the rest of the 3 months. So they have 2 months left in order to get the disease. Whereas in another hospital, you could have, 10% of that 50% get the disease in 2 months, and then the rest, the 40% get it in the last month. So rate is like an acceleration. So it's really describing, how fast something can go. So time is part of the denominator in rate. So as you can see on this example, it's the total time of disease minus the free subjects observed. Place and population are specific for each type of rate. And in rate, the numerator is not a subset of the denominator. So a little bit similar to ratio, but it's not a proportion. So that's what makes it different. It can't be expressed as a percentage or a proportion. And we'll talk a little bit more about rate and why it's actually preferred to use rate to increase precision and specificity when we're talking about epidemiological results and outcomes. Okay, so we're back to our map, and we're going to now talk about measures of frequency. Okay. All right, so these are two items or two concepts that I'm sure that you have seen before, incidence and prevalence. So let's just get a little bit deeper because these concepts or these terms are used a lot. I'm not going to go deep into this slide. I'm just going to go on to the next one because I think it actually explains it much easier. I really like this. So if you look at this graphic as like a pool, you can see that prevalence is the accumulation of all cases, the cases that are there that's already in the pool. It's not new cases, it's not old cases. I mean, it's not new cases in itself. It's not cases that are leaving. It's just the current state of cases within the pool. I mean, when I usually describe prevalence, I always talk about it as a snapshot of the current state because that's the easiest way to understand it for me. But prevalence is not static. So prevalence can increase when you have new cases, which is incidence, which we'll talk about. But prevalence can also decrease when some cases get removed from that, snapshot of the pool. So how do cases get removed? They can get removed if people die. They can get removed if people get cured, which is preferable. Now, incidence is just the new cases. And so you might have heard when we talk about COVID-19 a lot with reporting, a lot of times the new cases, cases in the last 24 hours, cases in the last, over the last 7 days, those are the cases that are reported. So that is incidence and not prevalence. And so the below equation I think is really helpful to explain the relationship between prevalence and incidence. So as new cases are added, so if prevalence equals incidence rate multiplied by the average duration of the disease, as new cases are added, the prevalence will go up, like I said. And if the incident rate goes down, then the prevalence will go down as well. So prevalence is quite dynamic. And you can also see that diseases that have a longer duration, so if the average duration of the disease is longer, then prevalence will be higher. So this is something that is really interesting. The way that diseases are expressed really come down to this. So usually when we're talking about chronic diseases or non-communicable diseases, so we're talking about diabetes, we're talking about hypertension, a lot of times that is expressed as prevalence because those are lifetime diseases, right? But when you're talking about more acute diseases, infectious diseases, communicable diseases, we usually express them as incidence. Now, something that I think on the continent we're all comfortable with or we are aware of is malaria. And malaria actually is often expressed as incidence. But when we look at malaria infection, it is often referred to in prevalence because, through seroprevalence surveys and things like that, we're trying to look at where is the amount of parasites within the blood of a population, and that can be expressed in prevalence. So I just wanted to say that because it's not a blanket rule, really. So, okay, just seeing if I missed anything. Okay, so going back to incidence and just looking at incidence, you can see from here that incidence can be expressed in two measures. So the cumulative incidence describes the risk, really. So here we see that it's amount of opportunity in numbers of persons at risk. While the incidence density here, it describes the rates. So it goes back to what we were saying about the frequency of a disease or, understanding the acceleration, the speed of a disease. So incidence density is rate, cumulative density, cumulative incidence is risk. So just for some definitions, so cumulative incidence, the numerator is the number of new cases. So when we think new, we think incidence. So that's easy for us to remember. And the denominator is the disease-free subjects at the start of follow-up. So incidence, we want to know the number of new cases. So we have to look at the population at risk to get that disease, and then we calculate how many new cases have gotten the disease from that population, and that gives us the cumulative incidence. Okay, so because incidence doesn't include a time variable, it has to be expressed in time. So you have to say things like, we're calculating the annual incidence. You wouldn't just say we're calculating the incidence. And incidence is really useful if you're looking at a specific period of time. So we use a cumulative incidence a lot when we are calculating the attack rate for an outbreak, for example. And this is the most common way to estimate risk, but it's not really helpful if the population changes a lot. So if you have a lot of attrition or if you have competing risk. So competing risk meaning that people will leave the population. Maybe they'll leave by moving out of the population, or maybe they'll leave by, if we're actually competing risk could be people actually die before they get the disease of interest. So this is not the best measure if we have a population that is more dynamic. Okay, so just a quick example of a cumulative incidence is the case fatality rate. And so it's a little bit confusing because when we think about rate, we don't think about risk, right? We're separating those two. But case fatality rate is actually a misnomer because it really does calculate risk. And I just wanted to say that it's actually not the only thing that is a misnomer. There's a lot of rates that we use that actually calculate risk and not rates. So, for example, if we think about smoking rate, and it's really the amount of adults that smoke over the amount of adults that smoke within a population, out of the amount of adults in the entire population, that's a proportion. That's not giving us a rate. So we actually do kind of mix those terms. But now that you know the definition, you shouldn't be so confused. Okay, so this example is looking at a case fatality rate and characteristics of patients dying in relation to COVID-19 in Italy. So here we have the setting. So it's Italy, so it's very specific. It goes back to the other slide that talks about it needs to be a specific place and a specific time as well. And we're looking at people who tested positive for SARS-CoV-2, so the virus that causes COVID-19. And we're looking at that over the total number of cases. So in the study, there were 1,625 deaths. So that's the numerator, over 22,512 people who were confirmed to COVID-19, so who were infected with the virus and had the disease. Okay, so that if you just do the calculation, that equals 7.2%. And so how this could be interpreted is that in Italy at that time, there were your chances of dying from the case fatality rate was 7.2%. Now at the bottom here, we have a confidence interval, and I know I haven't introduced this yet, but I'll just say something really quickly about it. A confidence interval is a way that we understand uncertainty, and it tells us if the results or the results that we have calculated are significant, if something that we can rely on. It tells us how weak or strong the value, the estimate that we have may be as well. And so in this example, 6.9 to 7.6%, it doesn't include the null value 1, which I will talk about soon. So it is significant, and 7.2 fits quite well within that confidence interval isn't too wide. So we would say that we have a higher amount of certainty that this value is close to the true value. Okay. So now we're going to talk about incidence rates, or also called incidence density. So as I said earlier, the denominator in the incidence rate is the total time that the people that have been observed. So it's including a concept called person time. And I don't think that is a super easy concept to understand, but it basically is saying that if you're in a study and so say you have 10 people in a study and you're observing each of those people over a year, at the end of that study, you will have 10 person years. So the reason why this is useful is because, like we said earlier, with risk, people can, when you're calculating risk, people can drop out of the study, and you don't really have a measure that helps you. When you're calculating risk and people drop out of the study, you actually, it's very difficult to calculate risk. You're not really reflecting what actually happened in that study. But when you're calculating rate and you look at person time instead of just a person, like a person dropping out doesn't have to be detrimental. If somebody spends 6 months within a study, then you can use that 6 months within this denominator. You can add that 6 months to the other time of the other people. Of the other people in the study, and then you can look at the exposure over those person years, those cumulative person years. And what that helps you do is to really understand the exposure at a population level. So remember, risk is really helpful when you're talking to individuals, and rates are really helpful when you're looking at a population level. So on this, so calculating incidence, density, or risk is a more sophisticated form of measuring incidence. It's also very difficult. It requires more resources, and really having to go into the data or even setting up the study to make sure that you capture person time. But it's a better measure than risk. Okay. So here is an example of remdesivir. So remdesivir, I think you all should be um, familiar with that, at least the name of this drug that has been seen to be effective in people to reduce their hospital time. So in this example, 53 people, well, this is an example, we have a study, and there's 53 patients who received remdesivir. So if you think about the cohort image that we talked about at the beginning of the lecture, these 53 people got the drug at the beginning of kind of their observation, and then they were followed up after 28 days. And the 28 days is kind of arbitrary, but just know that, these 53 people were being monitored and were followed up after 28 days. And these 53 people had COVID-19, they had severe COVID-19, and the hypothesis basically was that if they were giving remdesivir, then it would be some type of significant result that they wouldn't die, basically. So in this example, 7 patients actually died. So if we were calculating risk, it would be very difficult for us to, we could calculate a cumulative incidence, which we've done here, which is 7 over 53, but it doesn't really help us with a population estimate for this trial. So if you look on the right and you look at these bars, you'll see that there are 53 different bars. And so each bar represents an actual patient. And so you can actually see which patients, like if you look at the bottom, there is days. So you can see how many days the patient was actually followed up. And so the ones who made it all the way to day 28 are the ones, those are the ones who lived or stayed in the study. But you can also see, you can also see there are certain events that are marked with this black dot of people who actually died. So because we're doing a rate, we can actually just calculate all of those days. And Madhu and his student actually did this, and they calculated that there were 1,120 person days within this cohort. And so this would be interpreted as you see at the bottom, which is it's 7 out of 1,120 person days, which is 0.63 deaths per 100 person days, or 6.3 deaths per 1,000 person days. Now, I can understand that this is not the easiest interpretation to apply, but it's important to understand that this is how rate is expressed. Yeah, and so this is just a summary table of risk versus rate, and I think this is something that you all can go back to, but it just really summarizes what I've already described. Okay, so now let's talk about risk versus odds. So you all may be familiar with odds when you think about betting, or you think about probability expressed, in gambling and things like that. And so risk and odds are slightly different. And when we go over the 2x2 table, it'll be easier to see than this example or than this. But odds is the ratio of the probability of occurrence of an event to that of a non-occurrence. So when you look at risk, you look at the new cases, or you look at the exposed group over the entire population. But when you look at odds of a disease, you look at the exposed group compared to the unexposed group. So that is the difference. And so it's the odds that you turn this group who got the disease. It's the odds that the group that got the disease over the group that does not have the disease. And in this calculation, the odds ratio is 11% compared to the 10% risk ratio. So there is a point that the risk and the odds ratio can be similar, but it depends on the frequency of the disease, whether the disease is rare or if it's more common. I'll let Madhu if you want to explain on that, but I'm not sure if we need to go deep into that. Okay. So now we are going to talk a little bit more about prevalence, because there are two types of prevalence. There's point prevalence and there is period prevalence. Okay. So point prevalence is looking at, it's like its name, it's looking at prevalence at a certain point in time. And it's observed cases at time t over the population at time t. So again, just remember um, the snapshot image, because that will help you, really remember what prevalence is. And so the thing about prevalence is that while it's useful, it helps us to estimate disease burden at a certain time. It can only help us for that certain time. It's not dynamic. Well, it is dynamic, but it's not. It's not something that we can. If you calculate prevalence, so you calculate prevalence on July 16th, it's just the prevalence for July 16th. You can't apply it to other days because prevalence, as we saw in the other equation, can reduce or it can go up based on the new cases coming in as well as the cases going out. So we usually get prevalence estimates from cross-sectional studies, but it doesn't give us that temporal information. So period prevalence is a little different than point prevalence, because point prevalence is usually for a day or quite a short, or maybe 2 days, a short amount of time, whereas period prevalence is over a longer time. So it could be 6 months, it could even be a year, but it's not the same. It's still not the same as incidence, because when you're looking at your population, when you're calculating prevalence, even in period prevalence, so in 6 months, if we're looking in Johannesburg, if we're looking at a population in Johannesburg, there are people that can move, they can go to Cape Town, they can go to Harare, they can go to different places, there are people that will come in, but we're not really tracking that. We're going to include anybody that's in our catchment area. We're going to include them in the prevalence estimate. If they're there during the time that we're estimating prevalence. Okay. So yeah, the bottom just says, kind of what I've already said about the 1 year prevalence. Its proportion of individuals with the disease at any time during the calendar year, and it includes cases arising before and during the year, and the denominator is the total population during the time period. Right. So this is an example of point prevalence, and it's a study that was done in Santa Clara County in California, and it was done over 2 days. So again, it's that short duration, and the researchers did serologic testing, looking for antibodies in adults and children, and so they got a point prevalence of 1.5%. So 1.5% of I would say the population of Santa Clara County, looking at, because this is a sample, but a representative sample, they would say had the prevalence of the antibodies were in 1.5% of that population. And then the confidence interval is here, so you can see that it doesn't include one, and so this is a significant finding, and 1.5 fits within the 1.1 and 2.0, and it's not too wide. So this just talks about what prevalence is useful for. So assessing the health status of a population helps you with planning services. And like I said earlier, prevalence is very useful when you're thinking about chronic diseases and diseases that can't not be easily detected. So like hypertension, but it's not very useful for identifying risk factors or the causes, so the etiology of certain diseases. And it's also not good for acute diseases or diseases that have short duration. So I think this kind of just summarizes what we talked about earlier about what type of movement or changes or factors can affect prevalence. All right, so now it's a little bit of a segue, but I think it's actually very helpful that about when we're reviewing results or reporting results, really, I guess for this group, it would be more reporting results, is to, when you see words like crude rates or confounding factors or confidence intervals, is something to really catch your attention. because each one of these terms have a different implication on the actual study results and helps us to understand or contextualize those study results appropriately. Okay, so just quickly about crude versus adjusted rates. One here. Okay, so crude rates is just really when you calculate a rate, and so for example, if you're looking at the relative risk of a smoker to get COVID-19 compared to a non-smoker to get COVID-19, that's just the crude rate. You're just looking at two variables. You're looking at smoking and you're looking at COVID-19. You could say the same thing for this example that we have here. The crude rates, if you're looking at this study, which is it's just age distribution of the population between Sweden and Panama. Is looking at the death rate, and it looks like the death rate in Sweden is higher than Panama. But there are other variables that could explain why we have these results, and they're called confounders. And so in this example, the confounding variable is age. And when you have a crude rate, what you have to do is standardize it by you have to apply standardization of the different variables in order to adjust the rates. So the thing to be wary about with crude rates is if you see any type of research trying to compare a crude rate to another population, because that's just not, it just isn't appropriate. It really doesn't give you a true comparison. But if you can adjust for age, or adjust for gender, or adjust for whatever variable could be confounding, then it's easier, and it makes more sense to compare the different rates. Okay, so now this is talking about confidence interval, or confidence intervals. So let's think back to the Santa Clara County study that we were talking about, the serological survey that was conducted to see the presence of antibodies. So in that study, I believe there were, let me just look, I think there were like 3,000, yeah, 3,000 adults and children. So say someone tried to do that exact study again, and they got another 3,000 adults and children. It's highly likely that one, they would not get the same population, especially if they're randomizing, and they should be randomizing this study. But even if they got the same population, it doesn't mean that they would get the exact same results, because it's done at a different time. There's a lot of different factors that could affect the results. And so every sample that is used in a study is a proportion of a population. I don't think there's a study that has ever been done for the entire population of a place. If you think about, populations of countries like, Ethiopia, 100 million people, it'd be very difficult to, have a survey for 100 million people. It'd be very expensive, a lot of labor. It's basically impossible. And so what happens is that we do randomized samples that give us that reflect that the randomization helps us to have confidence that it reflects the characteristics of the population, and that's how studies are actually done. And since we're not having every single person in the study, we have to admit that there's going to be some uncertainty around our study results and the values that we get. And so that's why we have confidence intervals, because confidence intervals, they tell us that a 95% confidence interval is basically saying that if you estimated 95 different confidence intervals, that the true population prevalence, or the true study outcome, would be within that those confidence intervals, would show up within the 95%, the 95 confidence intervals. Sorry, this is a little bit tricky to explain. But in 5 of those confidence intervals, the true population, or the true prevalence, or the true outcome would not actually show up. So it helps us to kind of quantify the uncertainty. And I think what you should just take from this, that a confidence interval shouldn't include the value 1. So if if it includes the value 1, you're basically saying that there is no difference between two groups that you're trying to compare. Actually, I think we can look at this. Yeah, we can look at this example to explain it a little better. So in this, sorry. Okay, I think I might have taken out the hydroxychloroquine example, um, but that's okay. But there was an example of hydroxychloroquine, and it was showing that in the group that was treated with hydroxychloroquine and in the group that was not treated with hydroxychloroquine, the incidence in both groups were very similar. So when you calculated the relative risk of those two groups, can you guys please put your phone on mute, please? I think I can. Yeah, thanks. So when you calculated, the two different studies, you got a relative risk that was close to 1, and you got a confidence interval that included 1. So I think it's actually very difficult to explain. So maybe in a future slide I can actually show it. But if it's not in this slide, we have a larger, more comprehensive slide in the Dropbox, or sorry, in the Google Drive. So that would include that example. Okay. All right, so now I'm just going to talk about this 2x2 table. I'm not sure if you all have heard of it, but this is used a lot in epidemiology. It's called a 2x2 contingency table. And so we're just going to kind of take a tour around it so that we all understand it. So here we have different cells. We have the different rows, or sorry, different columns and the different rows. And so the first column is always the group that has the outcome. So it could be that has the disease, or that has a specific behavior, if that's what we're looking at. And then the second column is always people who do not have the outcome. So they do not have COVID-19, or they do not have malaria. Likewise, if we look at the rows, the first row is always the group that is exposed. So if we're talking about a behavior, they're smokers, where the second group is always the not exposed, so the non-smokers. So that's something that's kind of the right way to construct the 2x2 table. So what we have in cell A is the group that has the outcome, and they're also exposed. So if we think about the smoking example and COVID-19, it would be the people who had COVID-19 and also smoke. In B, we have the people who do not have COVID-19, but they smoke. In C, we would have people who do not smoke but still have COVID-19. And in D, we would have people who do not smoke and do not have COVID-19. And all of the rows should equal, so the number of participants in each group. So you should know how many people how many people are in the group that was exposed and how many people are in the group that were unexposed. And that makes it quite easy to kind of plug in the numbers and make sure that everything is correct. And same with the outcome columns as well. And so what do we use a 2x2 table for? It actually helps us to calculate those measures that we have just described. So if we're looking at a cohort study or a randomized control study, we can calculate the relative risk. And the relative risk is the incidence of the exposed group over the incidence of the unexposed group, or the not exposed group. And so if you remember the equations from before, incidence is new cases. So incidence is always new over the entire population. So it'd be the new cases in this group over the entire group population. And then we do the same for the not exposed group. So the new cases in the not exposed group over the entire not exposed group. And that's what you have here. So for case control studies, we have to calculate an odds ratio. And similarly to what I was saying before, an odds ratio doesn't look at the new cases out of the entire population. It looks at the new cases over basically in this one, it could be the new cases from A over C. So the odds of people in the outcome group. We could also look at the new cases in B over D. And you can also do it, yeah, across as well. So you can calculate the odds ratio in both ways. Okay, oh, here's hydroxychloroquine, sorry. I was mixed up in my notes. Okay, so now we're going to calculate measures of effect using an actual study example. So first we have 75 patients. They're in the experimental arm, so the arm that actually receives hydroxychloroquine. And then we have 75 patients that are in the standard of care arm, or this group of people, they receive a placebo. They don't receive hydroxychloroquine. And so now we need to plug in our numbers. We have 53 people who receive hydroxychloroquine. So in our 2x2 table talk, it would be like the exposed group. And here, these people have a COVID test that is negative. Then we have the same group that has a COVID test that does not become negative. We're going to say positive. And then we have people in the placebo group that do not receive hydroxychloroquine, but they take a COVID test and they have negative results. Similarly, we have people in that did not get hydroxychloroquine, but they get positive results, or they get a test that's not negative. And we have the same amount of people in each group. So we have 75 people in the hydroxychloroquine group and 75 people in the placebo group, 150 in total. So that's how we would read that with real examples. And so when we actually calculate the cumulative incidence, which is 53 over 75, and that's in the hydroxychloroquine group, then in the cumulative incidence in the standard of care group is 56 over 75. We get 70.6% and 74.6%. Now these don't look that like there's such a big difference, right? So let's estimate or calculate the relative risk, which is taking this 70.6% and putting that over 74.6%, and let's see what we get. We get 0.94, which is what I was saying earlier. It's very close to 1, and 1 is basically saying that there's no difference. It's like if you have 10 bad eggs and 10 good eggs, they cancel each other out basically, because 10 over 10 is 1, and there is you're not showing that there's any type of association between the exposure and the outcome. And our confidence interval is also telling us that. It's telling us that this 0.94 is not significant because the confidence interval crosses 1. So it's 0.78 to 1.15, and we know that 1 is in the middle of that range. Another thing we can calculate is the risk difference. So the risk difference just calculates the cumulative incidence minus the cumulative incidence in the exposed group minus the cumulative incidence in the unexposed group. It's just subtraction, and we get a negative 4%, again, which is really small. Like, so if we're thinking about what's the difference of if I take hydroxychloroquine, how do my risk differ when it comes to testing positive or negative for COVID-19? Negative 4% is not a strong outcome. It's really small, actually. And so what this is all telling us is that this does not seem to be an effect. It doesn't seem to be any type of association between hydroxychloroquine and testing negative for COVID-19. When we do the odds ratio calculation, we get a slightly a slightly different number than the risk ratio. But if we would also look at the confidence interval, it would, this basically this is kind of telling the same story, all these different estimates that we've calculated. Okay, so finally we're going to talk about the measures of potential impact. So It's actually a really important point, is that in any given population, people are going to develop the disease whether they have risk or whether they have exposure uh, to a certain characteristic or a certain behavior or not, or a certain hazard or anything. So, for example, uh, people can get lung cancer without smoking. There are other things that cause lung cancer. It could be, air pollution, asbestos inhalation. There are other things that cause lung cancer. So, what we need to look at is what is the baseline risk. So this figure on the left, you'll see this unexposed population, and this is the incidence of a specific disease. So the unexposed, there's already a certain amount of people that are going to get this disease, even though they're not exposed to a specific behavior or a hazard or anything like that. And so what we want to know when we're looking at measures of impact is what fraction of the outcome, like the disease, if we're thinking about lung cancer, can you attribute to the exposure? So in this situation, for example, we have, the exposed group, and they have a higher incidence. And what we want to see is the difference between which fraction of the actual people who get the disease can we attribute to smoking. So lots of data show that 80% of lung cancer rates are actually attributed to smoking. So that means that the other 20% could be attributed to something else. And so for COVID-19, this is really important because we want to know how much of the mortality is actually attributed to COVID-19. So when people are dying between February and let's say July, we want to know, is that excess mortality? Is that different from the past few years of people who died during the same time period? So you will read a lot about excess mortality or deaths that are attributed to COVID-19, or even deaths that are attributed to COVID-19 disruption. So say someone was supposed to get a surgery, or someone was supposed to have, someone got very sick and they didn't have access to their hospital because of COVID-19 overwhelm of the healthcare system, then those would also be deaths that could be attributed to COVID-19, or morbidity even that's attributed to COVID-19. So this is becoming more and more important as we try to capture what additional diseases and deaths are due to different diseases and conditions. So this is just graphs that kind of illustrate excess mortality in a given period that have been already calculated for different countries. So you can see the excess mortality in France and Spain and in Britain. And again, they're comparing this year's data, or this year's mortality, the mortality numbers, to observed numbers of deaths in previous years as well. So there are observed numbers of deaths for this year, and then expected numbers of deaths from the observations of previous years, and that's how you understand excess mortality a bit better. So yeah, that is actually where I am going to stop. Yeah, please let me know if you have any questions, or I don't know, if there are any questions that have showed up.
Yes, Ngozi, a lot of questions coming on. So
Okay.
we're going to start with this. This says, when do we use confidence interval and p-values?
So as a journalist, you wouldn't be using confidence intervals and p-values. It's more when you're reading studies, right? So when you're looking at a study that has computed something like a relative risk or different measures, then you would look at that confidence interval and look at it if it's wide. So for example, when you have smaller studies, so this is something that's happening a lot actually when we're talking about COVID-19. There are some small studies that we really have a lot of uncertainty on because there's not a lot of numbers, and the larger the sample, the more randomization, the more we can say that there's less uncertainty due to kind of individual factors. And so larger samples give us smaller confidence intervals, whereas smaller samples give us wider confidence intervals. And a wide confidence interval doesn't really help you to really understand whatever estimate that you're reading. It doesn't really give you confidence in that. So if I'm saying, okay, so you have, okay, let's say, I would say you have like a 70%, relative risk to, people who smoke have a 70% relative risk to get COVID-19 versus people who do not smoke. Let's say, I just made up those numbers. And then my confidence interval goes from like, they say like 0.2 to, I don't know, or 2 to 11 or something like that. It's just too wide to really do something with that calculation, with that estimate. So that's so confidence intervals kind of give you information about those estimates. And when we're looking at p-values, that's when you're trying to understand. So that's when we're doing like a multiple regression analysis or different statistical calculations. And that's when it's also quite similar when you're looking at, like, do we have confidence in a p, 0.005% or 0.005, does something fit within that p-value? Like, is it zero? I actually haven't done p-values in a long time, so I think it's 0.05 and 0.005, and that tells us if a study is significant, is statistically significant or not, basically. So that's how you use p-values in confidence intervals, but you shouldn't be calculating confidence intervals in p-values.
Yeah. Thank you very much, Dr. Ngozi. And the next question is, the question says, I want to know what is the real difference between case fertility rate and infection fertility rate?
Oh, okay. Yeah, sure. So case fatality rate is looking at the people who are confirmed with COVID. So they've gotten a test, and hopefully it's a PCR test, so kind of the gold standard, and they know that they have COVID. And they're looking amongst that population, so that's the denominator, people who have confirmed COVID. Amongst that population, how many people die, right? The numerator is how many people with confirmed COVID die. That's case fatality rate. Infection fatality rate is looking at anybody who's infected with COVID. And if you've probably read different studies, there are some estimates that up to 40% of people who have COVID-19 could be either pre-symptomatic or asymptomatic. So unless you're doing wide testing, unless you're doing some type of surveillance, you really don't know how many people have the infection, because a lot of countries have kind of only tested people who had gotten sick, especially at the beginning of the pandemic. So if you find out how many people are actually have the infection, and then out of those people who have the infection, how many people die, that's going to be a different number than case fatality rate. It's probably going to be much smaller, because there's probably a lot more people who have the infection that are not being captured in the case fatality rate than people who have the infection that are captured in the infection fatality rate. But I don't think that, I see case fatality rate much more. I think recently we started seeing more on infection fatality rate because testing has become more widespread in some countries.
Right, there's a last question here. Says, is it helpful to explain a high recovery rate and to keep reporting it, as well as a low case fatality rate, or might it be rose-colored spectacle reporting?
Can you say the second part of can you just read it again? Yeah, sorry.
Yeah, I said, is it helpful to explain a high recovery rate and to keep reporting it? And the next part says, as well as a low CFR, case fatality rate, or might it be rose-colored spectacle reporting?
Okay, may it be skeptical reporting. Okay, so as far as recovery rates, is it good to, I mean, the thing, I get, yeah, go ahead.
So I just want to say, I think what I understood from his or our question is, as a journalist, is it important to report on case fatality or CFR?
So CFR is case fatality,
or
right?
recovery, sorry.
Or recovery. So recovery is a bit difficult to report on sometimes because it's defined differently in different situations. And so like in some countries or in some localities, recovery means that you have had at least 2 COVID-19 tests and that are negative. And in other places, recovery could just mean that you didn't die from COVID-19. So I think as far as like the consistency, I mean, you would really have to know what you're reporting on with the recovery. I think, where I've seen recovery been helpful is when I look at, kind of larger, kind of a higher level, like if I'm looking at Africa CDC's website or something like that, and I see the amount of recoveries, and as long as they define it, then I might, it's helpful to me. And as far as a case fatality rate, I think, I guess that is what we're more likely to report on, and I think it makes sense as long as it's contextualized, as long as you're talking about the case fatality rate in a specific area, and also as long as you know that, especially in some of our countries in Africa, that there's not widespread testing. We're not really getting all the cases per se, and case fatality rate can be affected by those factors as well. So I think that it's okay to report on both, to contextualize your reporting. But there's, I guess the point of this webinar is to give you that context. I don't know, Madhu, do you want to add anything for that question?
Yeah, so my sense is that some countries are, governments are more keen in pushing positive numbers, and recovery rate is something that they like to talk about a lot. India is certainly doing that. To me, I still think case fatality is critical to know how well or poorly clinical cases are managed. And then in terms of how widespread the disease is, we still need to look at the true incidence of confirmed cases. So I think this is not an epidemic that can be captured by any one number. We need to track as many numbers as possible.
Great, thanks, Madhu. Okay, so we don't have that much time, so let's move on to the next lecture. One moment. All right, one moment, let me just pull it up. Okay, actually, sorry, let me change the share. Okay. All right, so now we're going to talk about epidemics and infectious disease dynamics. And this have very similar objectives as the last one, which is to help you understand terms and key concepts of transmission that's often used in media reporting when you're talking about outbreaks and epidemics, and also understand epidemic parameters and type of data that is needed to understand the dynamics of contagion in general. So when we're talking about infectious disease dynamics, what are we talking about? It's really the study of contagion, thinking about who gets infected, at what rates, that we've already kind of discussed, thinking about transmission, as well as impacts of interventions and control measures, as well as temporal progression. So when it comes to interventions and control measures, we're going to talk about that on Monday when we talk about steps of disease outbreak and response. First, let's just kind of define some terms that I'm sure that you all have heard a lot. So, yeah, can you see my screen when I don't have it in full? Or do I have to put it in full?
Yeah.
Yes, you can see it.
Yes, I can see it.
You can see it, but do you see the whole thing, or do you just see the main slide?
The whole thing.
Oh, okay, good. Oh, the whole thing, okay.
Yeah.
Sorry. Okay, that's fine.
Good.
All right, cool. So when we're talking about endemic, we're talking about a disease that basically has a baseline presence in a particular region or population. So I think one of the easiest examples of an endemicity, endemicity is malaria in sub-Saharan Africa, as well as in some other parts of the world. So in a lot of countries, like in Nigeria, in Congo, there is a baseline number of cases that are seen every year in malaria of malaria. You can say the same thing about meningitis in the meningitis belt that stretches from Senegal to Ethiopia. So there's about 20 countries that always get some number of cases of meningitis. So an outbreak is when that number goes over that baseline. So it becomes more than it's normally expected. And we'll talk a little bit more about this in the next slide, because I think it's important to know that even endemic diseases can have periods of outbreaks. And then an epidemic is when that outbreak becomes much larger. So I think people kind of are fluid with the definitions between outbreak and epidemic. So for example, the West African epidemic of Ebola, it happened in 3 countries, and so that's why it was, well, mainly happened in Guinea, Liberia, and Sierra Leone, and so that was why it's called an epidemic. But then also in Congo, there's we just finished an epidemic of Ebola. Some people call it epidemic. It was just in Congo, so some people call it outbreak, but it happened in several places in Congo, so people go back and forth. But usually when you're using the word epidemic, it's to capture a larger geographic area than outbreak. And a pandemic is when something spreads globally or to multiple regions in the world. It doesn't have to be in every region, but multiple regions, it's considered a pandemic. Okay, so just talking about endemic disease, so I just wanted to show this map of endemicity of the parasite that causes malaria. And it shows that even though it's endemic in most parts of Africa, it's still different. So as far as like the transmission rates and the prevalence, which is what actually this is showing, is the prevalence. It still can be higher in some regions and lower in others, and it can even be higher in some parts of a country and lower in others. You know what I mean? So when we think of endemicity, it doesn't mean that it's completely uniform. And then I wanted to give an example of kind of how you can report endemic versus epidemic and outbreak and things. It's actually, there are several cases that happen in the US every year. Not that many cases, about 17 cases, but it's, if you do sampling of wildlife and you'll find the plague in different animals. But because of COVID-19, there are a lot of kind of, I guess, sensational reporting about, oh, now we have plague and COVID-19 and a locust swarm and this and that. And so the thing is so this Healthline says, this Healthline article says, yes, bubonic plague is still around, and this is why you don't need to worry. And they go into the fact that it's endemic. This other Imperial College story talks about how bubonic plague cases are reported every year. And then on the right, we have an article that talked about a very big outbreak of, I believe it was pneumonic plague. It could have been, I think it was pneumonic plague in Madagascar. And so plague, most of it, 75% of plague cases actually come from Madagascar. So you'd think, oh, they had an outbreak, but that sounds like it's quite endemic. But cases range from about, I think, 200 to 800 a year. So that's still a lot more than 17 cases that is seen in America. But in 2017, they record in the plague season, they recorded up to 2,000. It was about, it was 2,000. So you can see that is a huge break from like that regular baseline of 200 to 800 cases. And so that was a huge outbreak that people had to actually go and support the Madagascar Ministry of Health to control it. Okay, so then I just want to talk a bit about pathogens and mode of transmission. And so we know that different pathogens, they cause disease, but we know that all diseases are not caused by different pathogens. So I just wanted to, take a step back before I go into this and say, there are diseases that manifest because of genetic, just inheriting hereditary genetic markers that could cause disease. There's also environmental exposure or chemical hazards. Different things cause disease, but when we're talking about infectious diseases, we're really talking about diseases that are caused by pathogens. And so there's different types of pathogens or agents. There's viruses, bacteria, parasites, and with parasites, I'm including worms as well. And there's also fungi. And so these are the different disease examples that are caused by these different agents. Okay, and so now when we're talking about mode of transmission, I think this is a really important point. So if we're talking about direct mode of transmission, that means that there is no intermediary host. There's nothing that needs to be infected before I'm infected. I can get infected directly from another person, or I can get infected, through airborne transmission. So if somebody sneezes and then I walk into it or something like that, or if it's, a true aerosol and it just comes through the air, through the air conditioning or the fence or something like that, like TB, then I can get infected that way, or directly through sexual transmission, like how HIV is one of the modes of transmission for HIV. Indirect means that there is an intermediate carrier. So you may have heard at the beginning of the COVID-19 outbreak that there was a lot of discussion about fomite transmission. So, it goes into like washing our hands and making sure that, if we do have virus, we're getting rid of it every time we come in from outside and whatnot. And fomites are objects that different agents can rest on, that can stay on and still be infectious. Now, we don't really know how much infectiousness can be conveyed through fomites for COVID-19, but we do know that for other viruses or bacteria as well. So that's what a fomite is. But we can also, so water can also be an intermediate carrier. So if you think about cholera and different diarrheal diseases, they are the kind of, water is like the host that really brings out their lethality, really. And then there's also vector-borne diseases like malaria, and then there's plague that, is in fleas that get on rats, then go to people. But there's other, you can probably think of other diseases as well, like Lassa fever, that is more indirect transmission as well. So this epidemiological triangle is really important when we think about epidemics and outbreaks. It's important to, go back to that table and think about what agent is causing the disease. And we're looking at outbreak investigation. We're really looking at different characteristics that can help us to identify the responsible agent. Who is the host that is either exposed to or harbors the disease? And where are the favorable surroundings and conditions to the host or to the disease that allow it to flourish? So these three factors are really important when we're thinking about transmission and outbreak and infectious disease dynamics. So here's an example of just multiple transmission routes that can come from bat pathogens. And you probably heard a lot about bats when we're talking about coronavirus. And so how can, viruses that affect bats, how can they actually get to us? So you can see here it can come through bat body fluid, so that's direct transmission. So maybe bat saliva getting onto your food and you eating the bat saliva directly, or you touching urine or feces or blood from a bat, that's directly, it can get to us. It can also be transmitted by intermediate hosts like other wild animals. So this is something that happened with SARS. They believe that a bat infected a camel, and then, I'm sorry, not SARS, but MERS, the Middle Eastern Respiratory Syndrome. And then the camel is what actually ended up transmitting the virus to human beings. It can go through vector-borne as well, so blood-feeding arthropods. But we could also have indirect transmission. So the bottom two are, the intermediate host, the vector-borne and environment are all indirect transmission as well. So for bats, we can be infected by them in many different ways. So I'm going to spend a little bit of time talking about the R naught and what R naught is and what R naught is not. And the reason why I'm doing this is because there's, I think the media or scientists as well, we use this a lot. And so I just want to explain it a little bit. So R0 is the basic reproduction number that is an epidemiologic metric. It's used to describe contagiousness or transmissibility of infectious agents. And R0 is actually affected by a lot of things, and we'll go into that a little bit deeper. But right now you can see from the equation that it's at least affected by three things: by the risk of the transmission per contact, by the contact rate, and as well as the duration of infectiousness. And so just a little bit of information about R0. If R0 is more than one, then the disease can be spread and an epidemic can occur. So if R0 really is how many people can one person infect. And so if you can infect more than one person, then it's that means that disease can be spread at an exponential growth, basically. If R0 is equal to 1, so this is when we talk about endemicity, like it stays at a stable level. It's not going to kind of just shoot out and increase quickly, like we've seen for COVID-19 and some other diseases. And if R0 is less than 1, so that you're infecting less than one person, that means that the disease cannot spread, and you can eventually the disease can actually eventually die out. So I think it's important to know that R0 is really used. It's really always kind of calculated as a mathematical model. It's used because we don't have epidemiological evidence to give us that information. We might have some, but we don't have enough to give us a very strong understanding of the actual transmission in a new or susceptible population. And that's another thing I'll say, is that R0 is usually used at the beginning of us trying to understand a new virus or a new disease, because R0 assumes that no one has immunity, no one has been vaccinated. So it's really telling you kind of the potential of the new disease or the virus. So I also wanted to show that R0 actually really helps us to think about interventions or ways that we can control the new disease or the virus infection. So for example, this first factor of looking at the risk of transmission per contact, that is a factor that is inherent to the pathogen, but it also is based on individual factors as well. So the pathogen may have higher transmissibility, but also there are certain people that may be at a higher risk of, of getting the disease. And so when we think about kind of countermeasures, we can think about vaccines, we can think about drug therapy, we can think about populations that may be exposed or to have a higher risk, risk of transmission in their workplace, for example. So K is the contact rate, so how many people each person is actually contacting. And that is really human behavior, right? So that's why when we're looking at how to reduce the R0, for COVID-19, knowing how it spread, we look at social distancing. And, at one time we had lockdowns at the beginning. So because that can affect the R0, it can bring it down so that it's not going to be spread. It can bring it lower to lower than 1. So the duration of the infectiousness, that's really an innate quality of the pathogen. And so for now, it's really nothing that we can do, with COVID-19 to kind of change that. But there is drug therapy for other things. So there's some antivirals actually affect the duration of influenza, for example. And so I want to also just kind of emphasize that R0 is not static. It's based on a lot of different things. But first, let's look at R0 across different diseases. So the higher the R0 really is, the faster it's one of the components that really influence the speed of. Sorry, I'm coming up on time now, actually, so I'm going to kind of go through this. But you can see that measles has a very high R0, meaning that one person can infect 12 to 18 people. Polio, one person can infect 5 to 7 people. Ebola, one person can infect 1 to 4 people. So there's R0 ranges. And you could also see that the mode of transmission really has a lot to do with kind of how high that R naught is as well, because it's much easier to get an airborne disease than a disease that you actually have to touch somebody, right? And especially if someone's already symptomatic, when they have Ebola, you're a lot less likely to touch them. So I just wanted to caution you all, because you are journalists and you will be talking about this a lot, but R naught is often, it's often misinterpreted and is misapplied, and it doesn't really show that R naught is not a biological constant, and that it can be modified through different interventions. Like I said, we can modify R naught by staying at home. We can modify R naught by drug therapy and vaccines and different things like that. And this just shows that, like, also context actually has a lot to do with R naught as well. So this is R naught for different countries. And you can see it change from measles for the same disease, but just different countries in different years. I wanted to talk a bit about effective reproduction number. So I'm not going to actually spend that much time on this, but it just shows that R naught is kind of this mathematical model mathematical measure that we do at the beginning of a outbreak or an epidemic. But if we really want to understand kind of the current, like what's happening temporally, if we want to know what's happening at this specific time, then we actually need to look at the effective reproduction number, which can be expressed as RE or RT. And this shows an example of how the RE, the effective reproductive number, decreased in Norway over 3 weeks from them doing specific interventions. Madhu, do you think I should stop? Because we're actually, I think, at time, or I don't know how many
more slides do you have?
I have, I'm on slide 14 and I have 24, so I have 10 slides left.
Okay. Is everyone able to stay on for another 10 minutes? Then it may be good to complete the lecture.
Okay. Really sorry, guys, but let me go quickly through this. So I also, thanks, Madhu. I also wanted to talk about epidemic curves. You've probably heard a lot about flattening the curve, and I wanted to really show what the curve is. So really, an epidemic curve is a visual representation of the date of illness onset for each case, and it shows us the number of cases for each day, basically. And it guides a lot of outbreak response and investigation, especially for new diseases. It helps us to understand what the disease is, what's the magnitude of the disease. And these examples here just show how the shape of an epidemic curve can tell us a lot about the disease. So here you have a continuous common source. So that means that maybe a group of people are being exposed to something that is infected, or that has a virus, or that, maybe I always remember with like a water fountain that had some type of hazard, and people going back and that. So you see that people just continue to get infected with this, and they have onset of illness, and then it dies out. Point source is more like, say a child at a daycare got sick, and everybody who touched that child got sick. And so it's just one source, one point that is causing the disease, but it's not like person to person, so it doesn't propagate. And so that takes us to the next one, which is a propagated outbreak, which is like COVID-19, it's like Ebola. That means that you don't know what the point source is. There's already, for example, like what we call community transmission, and anybody can get infected. And the thing to know about this, the reason why we have this kind of similar peak and then it declines, is because viruses can only exist with susceptible hosts. So sometimes the susceptible pool of people that can get infected with the pathogen, not just a virus, it reduces because people die, because a lot of people already have the infection, or it reduces because we have some type of intervention like staying at home or vaccines. And so this curve, if you look at the peak and then it goes back down, this is the curve we were really trying to flatten. This is just an epicurve of Ebola in Sierra Leone and Guinea, and I just wanted to show how epicurves can really show us magnitude, because when you just look at the numbers, it doesn't really do it justice. But when you can see like the magnitude of the Ebola outbreak in Guinea compared to Sierra Leone, of course both were horrible and a lot of lives were lost, but it definitely shows you the difference in magnitude. This talks about a little bit about the flattening the curve. And I think the main point that I wanted to make here is that it's important to remember that flattening the curve is looking at cumulative cases and not at new cases. If new cases stay constant, then you're not really flattening the entire curve, right? Like the only time the curve of cumulative cases goes down is when new cases is actually decreasing as well. And then this is just from the Johns Hopkins coronavirus tracker, two curves or two epi curves, one in South Africa and one in Egypt. And you can see that there is a downward slope in Egypt, whereas we're not seeing that yet in South Africa. But I think it also makes a point about not reporting too early. There's so many articles out there about South Africa flattening the curve. And really, it's good to, hail the interventions and the good work that people do, but we're just in the middle, if we are even in the middle of this pandemic. And so there's still, I mean, even Egypt could go back up if they let up on some of their interventions. Here's some terms that are also helpful to understand time intervals of disease transmissions, incubation rate, latent period, and serial intervention. And serial intervention really is that, I'm highlighting that because it's really important when we're thinking about how fast diseases are transmitted during an epidemic or an outbreak, because it's the average length of time between a case being infected and infecting subsequent cases. So we call that, so the first group that is infected is like generation 1. The second group is generation 2. And so the serial interval measures the time between generation 1 and generation 2. This just shows all these different terms that I just explained. And I want to highlight here that the latent period is when you're not yet infectious. You are infected. You've been already infected with the pathogen. For example, you've already got SARS-CoV-2, but you're not infectious yet. And then I think everyone may be familiar with the incubation period, where it's from time from infection to symptom onset. And so when we talk about COVID-19, a lot of conversation is being had about asymptomatic, so people who do not have symptoms but still are infected and are carrying the virus with them, as well as pre-symptomatic, so people who are infected and they haven't seen any symptoms yet and they're infecting other people. And so I just wanted to show you that this is common. It depends on, or it does happen, it depends on the disease. And so it looks like that definitely is the case for COVID-19. But for example, for Ebola, you have to show symptoms. You actually show symptoms before you become infectious. And so it just depends on the disease. And in fact, we're quite lucky that that's the case for Ebola. Then another term I wanted to explain was doubling time. And it's really just showing the cumulative incidence that we talked about in the last lecture. It's showing the time it takes to double that. To double that rate if everything it remains the same. And because it's a rate, you can actually use it to compare the increase of cases across settings. So I just wanted to show here that the people that had, the countries that had a higher doubling rate, so it took longer for their cumulative incidence to double, those are the countries that we usually commend for having better outbreak response, whereas the ones with a smaller doubling rate or shorter doubling rate, so less days, we usually characterize them as not really responding as well. And then herd immunity. So I know this is a term that is also thrown around, and just let's dig into it a little bit. So it's the resistance to the spread of contagious disease within a population. It means that a sufficiently high proportion of individuals are already immune to the disease. And it really happens, especially when you're vaccinated. And so for every disease, there is a different kind of level of herd immunity, and that's really based on the reproductive number. So, measles, it's so infectious, it's so contagious really, that it requires, I think about 90% or 95% of people to be vaccinated, or to before you have herd immunity. Whereas something else that's less transmissible would require less of the population needing to be immunized or immune before you have herd immunity. So that's something to remember. And it's also important that you remember that you can get herd immunity through letting the infection kind of run through the population, and that's like widespread infection. That takes a long time. It has a lot of detrimental effects, because of course the people that are vulnerable will pass away. People that are maybe not be vulnerable to dying, but they still may have high morbidity, like we're seeing in COVID-19. You know, people who have had the symptoms, who have disease, and that even months later they're still having issues. So that's, you know, the risk of letting the infection just go through the population without any type of countermeasures, whereas most of the time when we get to herd immunity, it's through vaccination. And I just wanted to highlight that this is just an article about vaccination campaigns in South Sudan, and that's still happening throughout sub-Saharan Africa. That's how we've really gotten to herd immunity for a lot of our, or we're trying actually to get to herd immunity for a lot of childhood diseases, especially like polio and like BCG, or tuberculosis, and, you know, measles, mumps, and rubella. I mean, vaccination rates are still quite low in a lot of countries, and they haven't reached the levels where we could have herd immunity, but that's really the most effective way to get there and to protect the population. I talk a bit about mortality rate and case fatality rate that I'm happy for you guys to go in and read about, and we talked a bit about it before. But with case fatality rate, I just wanted to kind of highlight the challenges that we kind of discussed before about really questioning what is the denominator. And as Madhu said, it's still effective to help us understand how to handle hospitalizations. But I think a lot are how hospitalizations are happening and how many people are actually dying of the disease. But I think that it's still, it can be used quite ineffectively, and it can be used to represent something that is not actually happening in some countries. So also, you know, this kind of goes into infection fatality rate. Like, we're not necessarily accounting for all pre-symptomatic and asymptomatic cases, so that's something to remember. Also, the more contact tracing we do, the more we're getting, contacts of cases that would also affect our denominator for the case fatality rate. So just know the case fatality rate, these different factors could lead to either an over or underestimation of a case fatality rate. Okay, I'm done. And just to say, next week, these are the things that we'll be talking about when we talk about outbreak investigation. So again, sorry for going over, but thank you.
Great job, Ngozi. So just so everybody knows, we will upload this entire lecture in a few hours once the video is converted. And then Ia and Ngozi will try to answer all the questions on the chat in more detail, and we'll post them on the Q&A. There's a couple of nice videos that Ngozi has already recorded on a 2x2 table. One of them is in French. So please go to the Google Drive and make sure you watch those short videos, because the lectures are a bit rushed, and 1.5 hours is really not a lot for the amount of material we're trying to cover. So these additional videos are quite helpful to solidify your understanding. So again, please rewatch the entire webinar. Look at those small videos that have been posted on Google Drive. And it's definitely a rushed format. There is no other way around it. So if you don't understand everything that was taught today, please don't panic, because we are trying to cover a lot in a few hours. But hopefully, as you stick with us and continue, things will get better as we go along. Okay, so please don't feel overwhelmed. It is definitely a lot of, like Ngozi said, it's like a whole new language. And we've all learned, spent years in epidemiology training, trying to learn exactly. I mean, I spent 5 years doing my PhD in epidemiology. So it's not something we expect you to get immediately. At a minimum, we expect you to get exposed to the concepts and the epidemiological way of thinking about things, right? To us, that perspective is more important than understanding the definitions of everything, okay? So we will see you again on Monday for the rest of the lecture on outbreaks and outbreak response. And for the last lecture on 30th July, we have quite a few topics we want to cover. So I would ask if all of you can give us 2 hours for that day alone. I will send a separate email to inform you about that. If you can give us 2 hours, then I think the last session on July 30th will be very good. Taryn will also be speaking to us that day on meta-analysis. Okay. All right, everyone. Bye, and thank you so much. Have a safe end of the weekend. Thanks, Ngozi.
Thank you. Bye.
Thank you, Ngozi.